and I'm really excited to announce our speakers. Dr. Emily Tajani is a triple board certified physician in child and adolescent psychiatry, general psychiatry, and addiction, and is a consultant to the UCSF Youth Outpatient Substance Use Disorder Program. And Dr. Matt Myers is assistant professor pediatrics and the assistant fellowship director for the Adolescent Medicine Fellowship, and also assistant director for the UCSF program. And we are excited to hear their talk today. Please know that the speakers have really tried to incorporate the questions that were submitted in advance of this, and also encourage folks to ask questions during the talk, and then there will be some time at the end for questions and discussion as well. With that, I'll turn it over to you.
All right, hey everybody, thanks for joining. So nice to see so many people here to learn about this important topic. I just wanted to reiterate what Petra said. Feel free to ask any questions at any point throughout, either by just asking us to pause and asking verbally or jotting it in the chat. I'll keep my eyes on the chat. So hopefully we'll be able to field any questions that you have as they come. I'm going to share my slides. All right, as you know, since you registered for this specific talk, what we're talking about today is engaging and supporting parents of youth with substance use and substance use disorders. Starting off with the obligatory disclosure slide, neither Dr. Tajani nor I have any conflicts of interest to disclose here. Wanted to go over a brief outline of some of the things we're going to cover in the next hour, starting with sharing the fundamentals of adolescent substance use treatment and the critical overlay of parental involvement, walking through some case examples from our own learned experience as providers working with youth with substance use issues, and sharing some learning points that we've gotten along the way. And then spending a bulk of time kind of exploring questions that were submitted prior to this session from you all, because I think they opened up a lot of really rich discussion. All right, so starting off with some helpful to share with parents. And this is kind of what I framed as really setting the stage as some of the important topics to understand and grasp when you're working with youth and parent couplets who are struggling with substance use. So one of the most important things to think about is your child, framing this in the conversation of us as providers with parents, does not need to want to stop or change before he or she can be helped. Ambivalence is normal, and it's the first phase of treatment that focuses really on eliciting and enhancing any motivation to change. And so it's very common that patients will come to us and be quite successful in treatment, despite in the beginning of treatment not having any desire to change, cut back, or stop their usage patterns. Another thing I wanted to focus on is taking an active role as parent in treatment that is not focused solely on complete abstinence is not enabling that usage. Knowing that you can make a difference is empowering, and sometimes it's a slow, involved process over time. Again, change does not happen overnight. Sometimes is what is effective short term is not effective over the long term and may cause iatrogenic harm, meaning some of the more intensive abstinence only focused interactions are not always the best approach for everybody. And so we'll get into more details of elaborating upon that in the slides to follow, but I wanted to lay that out there. Next point I wanted to make is, as parents, it's normal to feel scared and angry when you're seeing your child engaging in risky behavior. Ruptures in trust can often happen. They're common and they're expected, and they can and will be repaired with ongoing treatment and support. And also, it's okay and important to set limits that you need to maintain your own health and well-being. And I can't emphasize this enough, that self-care is critical for yourself as a parent working with children who are struggling with substance use related issues. So I wanted to highlight one of the main differences when working with adolescents with substance use and contrasting that with adults. So a lot of the research and a lot of the data on addiction medicine really stems from this sense that people have a high desire to want to change their usage, but a low perceived agency to be able to do so. And that leads to kind of a sense of helplessness around their substance use patterns. With adolescents, it's quite the exact opposite often in the initial phases, where adolescents will feel like they don't really have a desire to change. They cannot really identify any problems that their use is causing. And they have this really high perceived agency in their ability to do so. It's super common that patients will come to me and say, yeah, I smoke weed. I smoke all the time. It's fine. I'm doing okay. If I wanted to stop, I can just do it whenever I want, which kind of creates this sense of ambivalence around their use, which can often make the initial phases of treatment and engagement a little bit more challenging, which is why parental involvement is often such a critical part in that early beginning phases. So because there often is that ambivalence and that sense of high perceived agency to be able to make change and low desire, one of the main goals in the beginning phases of treatment is really thinking about motivation and how we can kind of engage youth in understanding their perspectives and really draw out some of their motivation for changing their usage patterns. Pausing for a second to see the comments. Okay, never mind. So, like I said before, there is often this sense of perceived agency and ability to stop usage and lack of desire. And so with that combination, youth don't often see a perceived need for treatment. And what we've known looking through the research is perceived need for treatment is really associated with higher level of severity. And so a lot of the patients that we'll be seeing will fall into that former category. And not really fully appreciate quite yet or understand the problems associated with their usage and thus not understand the need for treatment. As we're working with people and we're trying to build that intrinsic motivation, it's really important to understand that that motivation to either cut back or stop their usage really, in order for it to be a sustainable change, needs to be rooted in an intrinsic desire to change. And the less successful interventions are the ones that are based off of either suggestions or insistence that people cut back or stop their usage before they're ready to do so. So again, just to reiterate, the first step really in treatment for youth with substance use is to really try to understand their perspectives on their usage, understand why young people are using substance, and kind of use that information as a way to develop their intrinsic motivation for change. So to do that, one of the most effective tools is allowing people to share what they both like and dislike about using. Really thinking about one of the fundamentals of motivational interviewing, this is anchored in trying to elucidate and pull out change talk. And so if you can get people to kind of highlight some of the things they like and contrast that with some of the things that maybe they don't like, that allows you to get a foot in the door to be able to start to build upon that change talk, to build that intrinsic motivation that will help to contribute to the more long-standing sustainable change. And engaging in these conversations does not reinforce use. It really, again, allows you to begin that fruitful conversation of understanding their perspective and really helping to support them meet their own goals as far as reducing substance use. So again, motivation is malleable. Treatment is an individualized process of figuring out what works for each person. And again, to plug here, it's really important to understand why people are using to be able to create that individualized approach. Relationships are critical, as you all probably have seen in your practice. The stronger relationship you have with your patient and the more familiarity and comfort and safety they feel in your practice, the more likely they are to share with you some of the things that are considered more sensitive or may have been met with resistance, such as substance use. And so really building relationships with our patients is a really critical aspect of being able to provide care in this domain. And really just kind of thinking about planning and flexibility to operate together with your patient. Here, I will hand it over to Emily to discuss some of the other topics moving forward.
Great, thanks, Dr. Myers. So I'm going to follow up on what Dr. Meyer introduced, which is really this idea that it is important to first focus on a desire for change before moving along with trying to figure out how to help the youth change. People are more likely to change when they are personally invested in the idea that change is helpful and likely to be, an effective way to achieve their goals. I'm sure it will come as no surprise to most of you here, who I assume work with teens and young adults, that it's very rare for a teenager to call and make an appointment on their own, specifically to discuss their desire to stop using drugs or alcohol. Now, that is not to say that very few youth who use drugs or alcohol do not want to stop or change their use patterns. Many of them do, and many will have some having some sort of negative impact, at least on certain aspects of their life, but they either are not comfortable sharing those thoughts, questions, reflections with an adult, or they are not yet feeling that there's any other way to move forward in the present and deal with the difficulties or issues or reasons behind their substance use. This makes it hard for providers, for clinicians, and for parents to stay engaged and supportive and helpful to the youth. It can be frustrating to try to help someone who doesn't seem to want our help. And I think one important message we can communicate to parents is that what we see, what we observe in another person, the behaviors that we see, do not necessarily reflect any specific intention or any specific emotional or cognitive state. It's very hard to know from looking at someone, and sometimes even from talking to someone, what is really going on in their mind. So it can often be helpful to be really curious in your interactions with the parents as to what they're concerned about, and what sort of things they think are going on with their child and why, but to also explicitly let them know that curiosity between the parent and child is often a really good way to improve the relationship and enhance communication, and greater levels of honesty as to what's actually going on with that child. So a lot of times parents come in and at the beginning of the appointment will say something like, he really just cares about getting high. He used to be a good kid. He got straight A's and played soccer, but now all he cares about is getting high. And I just don't understand what's wrong with him or what's happened with him. This is pretty much verbatim words that we heard during our very first evaluation at YoSUP a little over a year ago. Meanwhile, while this parent, a father, was saying this, the child is sitting there with his hoodie on and eyes down, looking at his phone and, just kind of tuned out or appearing to tune out entirely, although it seemed fairly clear that he was probably hearing what his dad was saying and was hurt by it. And when we had a chance to talk to the child, or the teen, I should say, alone one-to-one, when the dad stepped out, that is what he shared with us. And he was able to get to a point of expressing that he's really hurt by the fact that his dad seems to think that he's just lazy and a bad kid now. And actually what's going on is he's had a lot of social anxiety. He hasn't made many friends at his new school. And he's sad, bored, and lonely. And he really doesn't want to be using marijuana every day, but he's really not sure how to feel better, and that the marijuana actually isn't feeling so good anymore. The initial euphoria and sort of fun that came with using has sort of faded, but he feels really bad when he doesn't use. So it kind of like blunts the pain to some extent. This is a book that's unrelated to substance use disorders, but I love the title. I'm not bad, I'm just mad. So by helping parents, kind of think about the wide variety of things that may be going on with their child, and to not assume that they know why they're using substances, is a very important message to communicate. Next slide, please. And along these lines, it's helpful to recognize as a physician giving advice to parents that ultimatums or a heavy emphasis on coercive or extrinsic motivators is unlikely to be helpful, at least over the long run. With minors, parents and clinicians may see some short-term success with forcing kids to do things, because legally you can often do that to some extent, although it can be very stressful and unpleasant for everyone. But what the research shows is that coercive approaches are generally not very effective, especially with young people. The evidence base with adults is a little different than what we see with teens and young adults, in that high levels of extrinsic motivation without a sufficiently developed level of intrinsic motivation to change are associated with particularly poor outcomes. And actually focusing too much on extrinsic motivators may actually decrease the level of intrinsic motivation for that youth, since adolescence is a time where young people are becoming more autonomous. They are sort of establishing their identities and are supposed to be working on their self-efficacy or agency. So if you pull too much and try to be too coercive, they're likely to pull back. Now, I do want to mention that the idea of a motivator is either extrinsic or intrinsic is malleable. So something that may initially be an extrinsic motivator can become an intrinsic motivator for the youth. And just a brief example of what I'm talking about here. A parent who tells their child, you're not allowed to watch TV or use the internet or your phone until you stop using drugs. That is an example of a strong emphasis on extrinsic motivation, because the parent has decided what they've taken away and what is not allowed until the youth does what they want to do. Now, a way to kind of shift that is if the young person is saying they really miss being able to text and chat with their friends and play games online, the parent, could sort of listen and validate that, and then perhaps say, well, I really would like you to see that doctor at the clinic that we talked about. And perhaps if you start going once a week there, we can give you an hour a day of time to play games on your phone with your friends. So you see the difference there. It's the same reward that the child gets in the end, but the child has self-identified and articulated the reward that they want, and the parent has approached it in a positive reinforcement way, as opposed to taking things away that the child feels they should have otherwise. Next slide, please. So really, we just want to help parents figure out a way to kind of change contingencies and make the benefits of not using outweigh the benefits of using. So it can be helpful at times to allow for natural consequences to happen to an extent. We generally don't want people, especially young people, to hit rock bottom. But if, there's a car accident and the car doesn't work anymore because they were high while driving, you probably don't want to pay for the whole repair for them and let them get right back to driving. So that's a way to allow for negative reinforcement approaches. We talked a little bit about positive reinforcement. We also want to make sure that parents don't get the wrong message about how their involvement matters. There can sometimes, in certain addiction treatment settings, be a heavy emphasis on this idea of enabling and encouragement to use tough love, to not engage with the person who's using drugs or alcohol. And that is, there's really no evidence to support that in a general sense. And relationships are often one of the most reinforcing rewards out there other than drugs. And so we want to harness the power of the parent-child relationship and let parents know that their involvement matters, even if their child doesn't seem to care what they think. They probably do, and they probably want a better relationship with their parent. It's not just the parent who wants this. And then just a classic Mr. Rogers quote, just about how important it is to be able to talk about things, to be able to communicate in words to another human being is, really therapeutic in and of itself. Next slide. And these are just, sort of a summary of the different ways, sort of the theories of change or the theories of the mechanism of change behind parental involvement in youth SUD treatment. Having parents involved can kind of take some of the shame or blame away from the child, and help the child kind of think about themselves as not just someone who's in trouble, but this is a whole system, issue. Things aren't going well. Let's figure out together how to fix this. We're all in this together. I mentioned just a minute ago about how a lot of young people, even young people who may be very upset with their parents, they want things to be better at home. Very few people want conflict in their lives all the time. And so, approaches that are aimed at decreasing conflict and increasing the level of the social support that a person feels they have are highly likely to improve their health, mental and physical. And using two-way agreements or two-way contracts where parents are invested and asked to change some things alongside the child being asked to change things tends to be most effective, because most people don't like to be the only one doing the work when there's a problem at hand. Next slide, please. This is just to show you that there is evidence behind what we're saying today. This is one paper, well, two different papers, graphs from two different papers, but there's many more out there. There's an overwhelming body of evidence that family involvement or family-based approaches to youth SUD treatment are effective, are at least as effective as any other treatment, and perhaps slightly more effective than individual or group treatments. And so family involvement has been shown to not only improve substance use disorder outcomes, but also leads to improvement in psychiatric symptoms, lower rates of incarceration, and less utilization of inpatient or residential treatment. And this survival curve over here just shows that when we have a treatment for adolescent opioid use disorder that involves family involvement, which is really what this recovery support is, versus treatment as usual, just medication and individual checkups, there's a lot less relapse to opioid use disorder or opioid use in the group that has family involvement. Next slide, please. I'm sure you're all very well versed in the effect that high levels of adverse childhood experiences has on a young person's later health, physical and mental trajectory throughout their lifespan. There's some research to suggest that family support focusing on improving parent-child relationship and family dynamics can actually mitigate against some of the risk that comes with high ACE scores and later substance use disorders and other psychiatric disorders. And I'll let you look through later some of the specific numbers here, but family support, even in a family who's had a lot of stressors, conflict, or experienced a lot of trauma, can still be helpful down the road. Next slide. So kind of to summarize the evidence base for family involvement in youth SUD treatment, family involvement has been shown to improve youth SUD outcomes, improve psychiatric outcomes, increase treatment retention. Youth have pretty high rates of attrition from addiction treatment or co-occurring disorder treatments. Family involvement reduces those rates. And also there's this added benefit of siblings and parents often benefiting emotionally and being able to function better when we use family-based approaches. Next slide. This is just a quote from the American Academy of Pediatrics. Parental involvement is essential to the success of us. Next slide.
Sorry, that was my fault. There's a little bit of a delay there.
No, yep, I think I had an internet issue for a sec. Okay. And this is from NIDA. It just shows, kind of the pathways that are involved in increasing likelihood of later development of a substance use disorder. And you can see that pretty much at every point, every potential pathway has something to do with a family factor. So SUDs are developmental disorders that result from environmental and biological determinants, and many of these determine protective factors. Next slide. This is just a recent journal article that I was thrilled to see published, and we hope that our presentation today helps you embrace this even more than you already are, that pediatric mental health care really needs to be family-based. Next slide, please. Regarding when to start doing this sort of work, it's never too soon to try to help your patients and their families prevent the incidence of a SUD in the next generation. Next slide. So NIDA has a really great open source guide called Principles of Substance Abuse Prevention for Early Childhood. It's backed by a lot of research and evidence. You can find that online. And while all young people are likely to benefit from the approaches that are covered in this guide, young people who have high ACEs, who have early emotional or behavioral problems, or who are growing up in situations of extreme poverty or violence exposure or other environmental stressors are most likely to benefit. Next slide. Excuse me. It's also never too late. Sometimes parents feel defeated, that they start to feel guilty when they start thinking, about everything that went wrong earlier in their child's life when they're coming in with a teen or a college student. And it's important to let parents know you can still make a difference. We can change things. There's evidence to support the fact that better adolescent and even young adult and parent relationships are associated with less frequent substance use, better mental health and functioning all the way up until at least midlife, probably later too, but they didn't measure that far. This picture on the left, Let's Talk, is a booklet published by a nonprofit group here in Marin, where I'm based, called Marin Healthy Youth Partnership. And it's a really good, easy to understand guide to help parents feel more comfortable talking to their kids about drug and alcohol use. And it's really based on what the research shows is an effective way to engage young people in these discussions. You can find that online for free too. Next slide. Just briefly, I wanted to mention that there's tremendous overlap in the neurocircuitry of addiction and attachment. And by attachment, I mean parent-child attachment, romantic attachment, and like social attachment. So by emphasizing and focusing on approaches that improve the relational support that a young person experiences, we can kind of compete with some of the reinforced pathways that have occurred along the trajectory toward addiction. Next slide, please. All right, Dr. Myers, I'm gonna hand it off to you.
Great, thank you. After outlining, as well as Dr. Tajani did, a lot of the important reasons why parental involvement is super important, I wanted to highlight what one of the tools we often recommend to families is, and that is CRAFT. And this is an acronym which stands for Community Reinforcement and Family Training. And it's a form of therapy that really is driven towards helping support the term is CSO, but it's concerned significant other. And so typically with our patients, that involves parents, but you can take a more expansive view on that to include caregivers or partners or whatever support networks exist around the person who is a little bit reluctant to access care for their substance use. And so this is really a model that helps support creating an environment around that person that supports them to feel comfortable in accessing that care and also promoting whatever their goals are, whether they be harm reduction, reduction in usage, or abstinence. And this has been really well studied and showed a lot of promise, particularly in the setting of youth with the parents getting the CRAFT training. And some of the data to support that really highlight the effectiveness of this when compared to some of the other treatment modalities that exist, such as alcohol or Al-Anon or a Johnson type of intervention. And so what we've seen is creating this network of support around a young person who's a little bit more reluctant to care shows much higher treatment engagement rates than some of the other commonly used modalities as well. Specifically, if you have providers who are trained in craft targeting youth as the person with substance use issues, we've seen this to be particularly successful. So this is a modality that we often recommend for families where you have a parent, guardian, and patient couplets coming in where there's disagreement on what the best next steps for care are, because this allows us to create support for the young person struggling by giving the concerned significant other, again, parent or guardian, the tools to be able to create that support at home. And so it puts a little bit of the empowerment moving forward in the hands of the parents in a way that can be really productive and helpful. There is an online guide. There are providers who are specifically trained to offer craft. And if patients can afford and have access to that, that's a really wonderful opportunity. However, the resources for that can be fairly limited. And so there is this guide online that I found, which is really wonderful. And it's a booklet that you can download for around $5 that really walks parents through in a self-guided way some of the core fundamentals of craft. So this could be a really cool tool to use for families moving forward as well. That's really accessible and effective. So I wanted to hand it back to Dr. Tajani to kind of walk through some of the cases that she's experienced in her practice and walk through some of the mistakes and what she's learned.
All right, thanks. After this, we'll go through some of the questions that you submitted beforehand, and we'll also open things up even more for questions and discussion. I wanted, though, first to share a couple experiences from my own clinical practice to, I guess, highlight that treatment is a process of figuring out what works for any given individual. And often mistakes, I guess, we could call the mistakes are made along the way. It's not uncommon to sometimes think that something is likely to be helpful for a young person with a substance use disorder, when in fact that approach does not work. And that does not really mean anything about one's own ability as the clinician or anything about the youth's ability to change. It's just a sort of a signal to modify the treatment, reevaluate, reassess, and try something a little bit different going forward. One of my addiction psychiatry mentors once said something that really stuck with me, which is that if you ever meet someone in this field of addiction psychiatry and co-occurring disorders who says, I know exactly what that patient needs, like right off the bat, that's sort of a red flag, you know. And unfortunately, in the field of addiction treatment, not so much the medical side of things, that's something that parents hear a lot. They hear, this is exactly what you need to do, and if you don't do this, it won't work. And so we want to move away from that. And we want to also educate parents that there's unfortunately often not one single easy, immediately effective solution. And that this is going to take time, but we're going to keep working at it and, you know, not give up. We're going to keep trying until we figure out what does work for your child. Next slide, please. So I wanted to just share a confidentiality error. Sorry, I'm just gonna look at the chat here. Yes, oh, perfect. We'll go into some detail in a minute about sort of confidentiality rules, the legal and clinical things to consider. But let me share this case example where I created a trust rupture with a patient that was very hard to gain her trust initially. And it kind of made a little slip up with the way I was handling confidentiality with her. So I'll call this patient Kelly. She was a 17-year-old young woman who had a history of sexual abuse by a former boyfriend of her mother. And she now currently had diagnoses of PTSD, ODD, and she had increasingly been using benzodiazepines and alcohol often together at the same time. Her parents were divorced. Her mom was in treatment, or kind of in and out of treatment for BPD, and her dad, who was the primary source of financial support, lived with a new wife that the patient really did not like at all. And the dad brought her into treatment. She was very angry about being there, and for the first several sessions really didn't talk much at all, and expressed a lot of doubt and skepticism as to whether I, as the doctor, could be helpful to her. And a lot of those themes kind of focused on trust issues that the patient had due to these adverse experiences early in life. And while I said right from the beginning, as I almost always do to the patient and the parents, that everything we talk about is confidential, and as not only an adolescent physician, but someone who specifically provides addiction treatment, I cannot share with parents any information about that child's drug or alcohol use without her permission, with the exception of if there's imminent risk of harm to self or others. As we went along, I didn't revisit that policy frequently enough. And while the patient actually gave consent several sessions in for me to tell her parents diagnostically what I thought was going on, and to share my treatment recommendations with them, and to even share information about her substance use disorder diagnoses, there was one occasion where she told me about a pretty risky situation she had been in, where she had used a lot of Xanax along with alcohol and had blacked out. And after she left that day, I looped in her parents and called them. And I did not specifically tell her during that session that I was going to do that day, and that I was going to tell them the situation and what she had used on that day. And so I was operating under the assumption that she would be okay with this because she had signed and given verbal consent. But she was very upset when she found out that her parents knew and that I had told them. She was particularly focused on how she couldn't trust me anymore because I didn't tell her first. And that's where I realized my mistake, that I should have cleared with her right in that moment exactly what I was going to say and when. And so that's what I always try to do going forward. Even when I've gotten consent several times to involve parents, I will do my very best to let a teen know when I'm going to reach out to their parent and what exactly I plan to say, and check in with them about whether that's okay. So this patient refused to come see me again, and it was really unfortunate. I felt terrible because we had been working together in psychotherapy for several months after a really rocky start. The good news is, though, there was a very good outcome in the end, and that eventually, through continuing to work with her dad and coaching him on some positive reinforcement and negative reinforcement approaches, we were able to get her to go to a residential treatment, which is really what she probably needed to get out of some of the risky situations she was often finding herself in at home and around the home. And like 3 or 4 years later, the dad contacted me with a referral question for someone else in the family and told me that his daughter had been sober for several years and, was really doing well and was working, had a job that she liked, and, good friends. So by staying in contact with the dad during those initial weeks when the patient refused to come, we were able to modify her trajectory. And, I suspect if dad hadn't gotten support about what to do and kind of how to still be helpful to his daughter, it would have been a lot harder to reach her and get her the help and support she needed. But it would have been great if I had been able to maintain the treatment alliance with her and not make that trust rupture. Next slide. I'll just briefly describe the, next, there we go. Okay, this one, I'm not going to go into as much detail on this case. What I want to communicate here is that there's a lot of different people who provide addiction treatment. And I kind of say that in quotes because treatment is broadly defined. in the world of addiction. It's different than other areas of medicine, where if you have a problem with your lungs, you're probably going to a to a medical center, to a clinic. I mean, sometimes you may not. I know there's a lot of different types of providers out there. But addiction just has a number of people that come to the sort of industry, if you will, from a variety of backgrounds, and who sometimes have no professional training or licensure. And it can be tricky because parents may be getting advice from many different types of people, some professionally trained to provide advice about addiction, and some who are not, who are perhaps drawing from their own personal experience, which may or may not be relevant and likely to be effective for the child of the parent that's speaking to that person. And early on in my practice, in my years out of fellowship, I found it could be kind of nerve-wracking at times, and confusing about trying to hold on to my lane and to not feel pressure to sort of support what someone else who was recommending to the parents, especially if they had been in the what I'll call industry for a long time. But over the years, I found actually it was often very important to do this, because I would see parents getting advice that could sometimes not only not be helpful, but could actually lead to quite a bit of harm. A common thing I see is kids being transported, is what it's called. It's essentially kidnapped in the middle of the night and shipped off to a treatment facility, often out of state, like a wilderness program. And I've had a number of patients that I saw after they had been at such facility. Often they went in because they were using alcohol and marijuana, and after they came back, they now had a greater number of sort of traumatic sort of experiences. They may have PTSD. The parent-child dynamic was much more impaired, because many of these kids are quite hurt and upset by what happened. And often I would see them progress to using other substances fairly quickly. Now, that might have happened anyway. It's hard to know. But generally, we want parents to recognize it's important to collaborate with your child, and to do things that are not going to lead to further impairment or distress in the relationship with them. Next slide, please. And this is just a nice quote that I think highlights how every case, every situation is different. So we can't use a one-size-fits-all approach, which may be frustrating, but I think it's kind of interesting. That's what makes the work interesting. Next slide, please. All right, so we're going to cover some of the questions that were submitted ahead of time. Feel free to unmute yourself and ask for clarification, or share your own experience as we go through these questions, or ask additional questions. I think we should have a little time for open-ended questions at the end. There's just a few that we're going to cover here. So this question is, how can one engage a parent that does not see substance abuse as a disease, but instead sees it as something criminal or evil? So this comes up fairly often, and actually there's some data to show us just how often. About half of youth and parents perceive addiction as a behavioral problem, and less than a third think of it as something that is a medical disorder, which may kind of explain why many people do not go to their doctor at first when there is a drug or alcohol related issue. So we want to kind of shift that and encourage discussion about drug and alcohol use and substance use disorders in primary care and all medical and clinical settings. But what do you tell the parent? So I think the most helpful thing is to first provide just a little bit of a basic overview about the brain and how the brain is affected by experience, including substance use. And there are changes in the way the brain works that occur with substance use that make it a lot harder to stop using than one would assume if one has not had that disorder before, if one has not experienced a substance use disorder. It's also important to let parents know that when people or children feel blamed or shamed or labeled, they're less likely to get help and to want help and to like really engage in their treatment. And what I do kind of practically is I'll try to just sort of ask the parent questions and try to understand why it is that they see their child's behavior as criminal or evil. And then I'll try to ask questions that help the parent remember some of the good things about their child. And often then they can kind of reframe the way that they are thinking about their child's substance use over time. Next slide. So this question is, how can we best approach substance use as self-medication? Sorry, I can only see part of it. Is this self-medication in the setting of anxiety or depression when the patient or family is reluctant to participate in behavioral therapy, or perhaps we'll just say therapy in general? So this is actually a really important question, and the field has sort of gone back and forth over the years. Decades ago, many addictive disorders were thought of as sort of self-medicate, a form of self-medicating. And then in the 90s, when there was more of an emphasis on biological psychiatry, that theory like really fell out of favor. But now we know actually there's usually both sort of pathways involved, especially for people who go on to develop moderate to severe substance use disorders. We know that substance use changes the brain and results in very specific neurofunctional deficits that characterize addiction. But we also know that people who use substances to cope, as opposed to people who use mainly for enhancement reasons, like to have more fun or to have a new sort of experience, the people who use for coping reasons are more likely to progress from substance use to a substance use disorder. They are also the people that are most likely to benefit from treatment. So understanding that can help us appreciate, and hopefully help the parents of our patients appreciate, that it's important to address both factors, and ideally at the same time. It's not one or the other. Both things can be going on, and the best outcomes generally occur when we provide integrated treatment for the psychiatric issue alongside the substance use disorder. Next slide. And Dr. Myers will go through these questions with you.
Sure. The next question that we got was, how do you address requests for drug testing? And I think this is one of the biggest questions we're often asked, and one of really important pieces in a comprehensive care plan for young people, but must be done in a very specific way to be supportive and helpful. So I would say, first and foremost, I would strongly advocate against using drug testing either at home or in clinic as a gotcha moment. And what I mean by that is youth should always be aware that testing is being done and should consent to that process without any coercion from parents. If parents come into clinic and say, I think my kid needs to be drug tested, I think the first thing I would ask them is like, why are you feeling that way? Help me understand what led you to this place. And really trying to better understand what their concerns are and why they're concerned, and why that's something that they feel like they're advocating for in the care plan for their child. And then once you understand that, asking their permission to open the dialogue about that with the young person. And again, doing that in a way that is absent of coercion from parents. And the only way to really effectively do that is to do that confidentially with patients one-on-one. Again, another plug for a really important reason to really have a strong, tight confidentiality statement before you go into those one-on-one conversations too. Oftentimes, youth will come in with their parents, and parents will feel strongly about wanting to do drug testing. Whereas the young person, not surprisingly, will not really feel interested, kind of see it as an invasion of their privacy. Oftentimes will say, I don't know why my parents are so worked up, I'm not even using any drugs. And in that kind of situation, I think it's kind of helpful to frame it with the young person as a way of kind of sharing and reflecting that maybe there's a little bit of a breakdown in the trust between them and their parents. And this can often be a tool to kind of help rebuild that trust. And installing with their consent a program that does include urine testing could be a way of objectively giving feedback to the parents that this young person is not using substances and kind of allow them to repair that relationship that way. Again, I just really wanted to reinforce that that is something that has to have buy-in from the young person and have their consent as well. If you get to a place of kind of communicating with the young person about drug testing, really important to share with them what the testing is going to look like, what the reasons for doing the testing are, and really kind of reinforcing doing it in a CLIA certified lab. Both the AAP and ASAN, the American Society of Addiction Medicine, strongly endorse only doing drug testing in a way that is done in a lab, and are strongly against using home tests. And so that's something that I wanted to share as well. And us as providers, if we get to the place of working with a family, some tips on how to effectively do urine testing. There's a few things I wanted to have you aware of. Number one, not all substances that youth are using are going to show up on screens. I've had a few patients tell me recently, you know, these screens that you're doing, they're not really working because there's a whole bunch of things that I'm doing that you don't know about, and I feel like I have to come clean, which was really nice to be in a place where somebody felt comfortable to share that with me, but also made me wonder, what are these substances that are being used, and how can we better expand our profiles to better understand and appreciate those in testing? Right now, there are certainly substances that are out there that youth can be using that might not show up on screens. And so if there are no unexpected findings in urine testing, but there's still concern, that's something to think about and have in the back of your mind. Screening tests are different than the confirmatory tests, and a lot of the screening tests that you can order for emergent services, if somebody presents to urgent care or the emergency department and acute intoxication, are valuable in that they give you immediate feedback on what substances have screened positive. But the more comprehensive, expansive drug tests that we use for monitoring are a little bit different and take several days to come back, but because of that are much more specific and sensitive. Testing, if it's going to be a component of your care plan for young people struggling with substance use, is best done if you do it randomly. And by that, I mean, what we do in our practice is testing once a week on a different day each week. We have a random number generator that tells us which day of the week that week is going to be the day that testing happens. And I think that's really important because with the differing pharmacokinetics of different substances, if you do have testing on a random day with the expectation of giving a sample within 24 hours, it really limits youth's ability to kind of take advantage of knowing what day the test is going to happen and prepare and plan their usage around that. So it does allow you to more accurately capture the episodic nature and better understand in a way what usage patterns may look like. And I will also say, drug testing is not absolutely mandatory for addiction treatment. It is a useful tool to get objective feedback, but it's not absolutely necessary. So again, some of the goals for drug testing when we do it are to monitor the response for treatment and adapt the treatment plan as needed when we do find unexpected substances in the screens. And that allows parents also to get feedback if youth are comfortable with us sharing that information with their parents. The next question we got was, it would be great to review outpatient resources for substance use treatment. And this is also one that I get a lot of messages about. I have this young person in my clinic that I'm really concerned about. What are some of the resources that exist in the community if I feel like this is beyond my level of expertise? And as the assistant director of the YoSUP program, I'd be remiss if I didn't put a plug here for us. We have a comprehensive multidisciplinary outpatient team that involves psychiatry, medical providers, a nurse practitioner, a social worker. We work with community therapists, and we have a program to do regular urine testing. And so we do have a fairly comprehensive outpatient program if outpatient level of care is appropriate for people. One of the Adjuncts to that is parent guidance training, which is similar, but a little bit different than the craft modality that we talked about earlier. Also, the craft online course is another great resource to connect families with. There are some youth-focused Al-Anon or support groups, even some with specific population foci. So that's a tool that you could potentially connect young people with if there is interest, in conjunction with some of the other treatment modalities that exist. And here in this table on the right, I outlined in the Bay Area some of the outpatient programs that we have heard of and worked with that we've had good feedback about. So just to be aware of some of these programs. Happy to share more if people have questions about that specifically. Oh, I did get a question in the chat about Medi-Cal. Yes, we are a clinic embedded within the Division of Adolescent and Young Adult Medicine. So we do see patients with any insurance, private or public, including Medi-Cal. And we also see patients whose primary medical home is outside of UCSF, including the general or other Bay Area counties. We are doing all of our visits by telemedicine, so people that are a little bit further away, it is accessible to them as well.
All right, this was the last question that we covered in the slides, and I know we're just about at time. I can stay on a few minutes and answer questions if people would like to keep talking, but I know some people are going to have to go. Instead of answering this specifically, I'll just put out there that there were a lot of questions about how to help teens not start using cannabis or use less often. And I think in the presentation today, we kind of covered the fundamental principles that are likely to help achieve this goal. And hopefully we gave you a good sense as to how to involve parents and empower parents to support and guide their child being able to have better and healthier behaviors and ways. So if anyone would like to ask a question, several questions or a comment, I'm happy to take that. Dr. Myers, I don't know if you have clinic right at 1 or if you want to stay on for a couple more minutes.
I can stay for a few more minutes to answer questions, but I do unfortunately have to go fairly soon.
Okay, maybe we'll stay for like 5 minutes. If anyone would like to chime in, please do so.
This is Tajani Goldstein. I do have a question about the program in particular. For once we make that referral, what exactly happens next? And if the teen is not interested, just a little bit more details that we can understand what happens once they make a connection with your program. Thank you.
Of course. We do, like I said, accept referrals from anywhere throughout the Bay Area, and our intake process is stretched over several visits. We feel very strongly about really understanding usage patterns and what's driving those, and really making sure that we have a good sense of the comprehensive structure around a young person. So our visits, the intake is really 3 separate visits, which include parents meeting with a social worker, the medical team meeting with the patient directly, and then if we feel like there are undertreated or underdiagnosed mental health needs, the second visit is with Dr. Tajani for a psychiatric evaluation, and that's a really useful tool in creating that comprehensive care plan. And then the third visit is when we really focus on putting together our treatment recommendations. And so it is a fairly long interactive intake process, but that allows us to make sure that we are specifically in an individualized way meeting the needs of each person. If people are referred to us in the first visit, we often share what some of the core components of our program look like. We have had people who have come and said, you know what, I don't think this is for me, but generally approaching it in the way that it's us trying to gather information about them to know how to help has gotten buy-in even from some fairly reluctant youth.
Thanks.
I have a question. I see patients in the juvenile justice system. So a lot of them are in the foster care system or in group homes. So there's really no parent involvement. And I would say like most of them, you know, tell me they use marijuana multiple times a day, but they've had a lot of trauma in their lives and, you know, don't have a lot of access to mental health and are sort of treating their PTSD or other psych diagnoses with this. And I don't know exactly how to, you know, get them to sort of realize, or like they're just like, this is what I'm doing and this is how I'm dealing with it, and I'm gonna just continue. So I don't know. Just
that's a great question, and thank you for bringing up the important point that sadly some people do not have parents in their lives. How can we support those youth? I think trying to find other forms of social support, ideally a supportive adult. It doesn't have to be a parent. Getting some sort of supportive adult involved in that young person's life is likely to be helpful. And there is some research to show that it doesn't have to be a parent. Sometimes it's a teacher. Sometimes it's a family friend. It can be someone else. But basically that person needs to be someone who's, you know, hopefully not currently suffering from a substance use disorder themselves. And most importantly, it's someone who's able to be there in a reliable and consistent way, and who can take the time to be patient and listen and try to understand. So for cannabis use disorder specifically, there's a lot of research to suggest that young people with high ACEs or with depression are at much greater risk of developing a cannabis use disorder, and depression also is worsened by a cannabis use disorder amongst other harms of ongoing cannabis use. But talking about that specifically in like a didactic way is unlikely, as I think you kind of mentioned and have experienced. It's unlikely to be helpful to the young person immediately, at least. So really just trying to form a relationship and try to understand what they're going through, understand what their life has been like, and trying to create some sort of narrative for them is a great place to start.
okay, thank you.
And as much as we would like to have everyone, you know, recover from their substance use disorder immediately and permanently, unfortunately, that is not usually how it goes. So I think it's important to recognize that it takes time, like for any chronic illness, you know, whether it's SUD or diabetes or hypertension, you know, often it's going to take some time and ongoing support, perhaps for the rest of their lives, in order to stay in recovery or remission.
All right. Well, thank you, everybody. I do have to go, but it was really great seeing all your faces. Take care. Have a good weekend.
Thanks, Dr. Myers. Thank you, everyone, for joining us today. If you have any follow-up questions, please feel free to send them to us through the contact information on our invite, and we'll get these slides and this recording up on our website.